And so I want to acknowledge Ken, and I won't be choked up the rest of the day. So, Dr. Lin, I'm going to turn it over to you as moderator of the brain cancer section, and also you're bringing Dr. Lee on board. Thank you so much.
Okay, so let's start the brain section. Dr. Lee will be the first speaker. Okay, she's going to, so she's going to control the slides. Dr. Lee, you can share your slides now.
Can you see it?
Yes. Oh, you need to, yes, move to the other side.
Okay.
Okay, that's good.
Great. Thank you so much for the very kind introduction by Dr. Ink. And I also like to thank the organizing committee, particularly Dr. Lin, for the invitation. It is a great honor to have this opportunity to speak with you on a topic that I feel particularly passionate about, which is management of the brain metastasis. So these are my disclosures and learning objectives. So there are 4 areas I would like to focus on for today's presentation. I will review the most recent updates in each area and discuss the controversies and future directions. So those areas are management of multiple brain metastasis, management of resection cavity, incorporation of brain radiation with immunotherapy and target therapy. So the first subject is management of multiple brain metastasis. We all know that whole brain radiation has been around for forever. It's widely available. It can treat microscopic as well as gross disease. However, it's associated with significant cognitive side effects, and it can cause interruption of systemic therapy by at least 4 to 6 weeks in a patient population that oftentimes needs systemic therapy for their extracranial progression. So I'm sorry, this is okay. On the other hand, stereotactic surgery spares normal brain. It's a one-day procedure. It causes minimal break in systemic therapy. However, it does not address microscopic tumor. It's limited by the number and size of lesions we can treat. It does require close surveillance and salvage treatment. So there have been at least 4 or 5 randomized trials evaluating the role of whole brain radiation in patients with 1 to 3 or 1 to 4 brain metastasis. The 2 trials I listed here are particularly important because they used cognitive function as the primary endpoint for the evaluation, as cognitive function was increasingly recognized as an important outcome for this particular patient population. So the first trial was performed by Dr. Eric Chen when he was at MD Anderson Cancer Center. So the trial was terminated early after a planned interim analysis showing that addition of whole brain radiation caused cognitive decline without prolonged patients' overall survival. These results are subsequently confirmed in a larger trial run by Alliance. So the Alliance trial again showed that when you add whole brain radiation, patient has worse cognitive decline, and even though whole brain radiation helps with the local intracranial control, it does not prolong patient survival. So these trials established SRS as the standard of care for patients with 1 to 3 brain metastasis. How about patients with 4 or more brain metastasis? Can we use SRS? For the longest time, the only evidence we have is this Japanese registry study where patients with 1 to 10 brain metastasis were treated with SRS. The goal of the trial was compare the overall survival of patients with 2 to 4 mets versus those with 5 to 10. They were not able to observe a difference between those two cohorts. As you can see, the overall survival is about 11 months. So they cautiously concluded that SRS might be a suitable alternative for patients with up to 10 brain metastases. So, but keep in mind, this is an observational study. We still had no level 1 evidence to support the use of SRS in patients with 5 or more brain metastases. And this is why we launched a phase 3 randomized trial in patients with 4 to 15 brain metastases in 2012. So that was 8 years ago. So the patients were randomized to whole brain or SRS. The primary endpoint of the trial was memory decline at 4 months as measured by Hopkins Verbal Learning Test, the total recall. So the other primary endpoint was local control. So we closed this trial early after achieving about 70% of the accrual goal. And in a few slides, I will explain to you why. So basically between September 2012 and September 2019, 72 patients were randomized with a median follow-up of about 6-7 months. The median number of brain metastases at the time of enrollment is 8. 62% of the patients in the whole brain radiation arm received momentum. So now looking at the results of the primary endpoint, which is HVLT at 4 months, we observed a statistically significant difference between the two arms in favor of SRS arm. Basically, the patients who received SRS had a better memory at 4 months compared to patients who received whole brain radiation. So not only there's statistical significance, if you look at the actual size of the benefit, is also clinically meaningful. We also looked at a composite score combining different tests, which gave us a better global assessment of patients' overall cognitive function. We also observed that statistically significant, clinically meaningful difference between the two arms, again, in favor of SRS. So for the other endpoints, we did not observe any difference in overall survival. The local control at 4 months was not different. Time to distant brain failure was different in the numerically, but did not reach statistic significance. So more detailed results will be presented at ASTRO in October. And I would appreciate if you don't share these results outside this conference. So as I mentioned earlier, momentum was used in 62% of the patients who were enrolled in our trial. And this is because in 2017, Paul Brown published the momentum trial, which is a phase 3 trial in patients who received whole brain radiation. They were randomized to receive placebo and momentum. Momentum showed showed that patient lead to superior memory, speed of processing, and executive function. So it became the standard of care for patients who need whole brain radiation. So after that, we encouraged our patients on the trial to take momentum, but we didn't mandate it. So my whole brain versus gamma knife trial endured 2 practice changes during its course of 8 years of running. So the second practice change was related to hippocampal avoidance whole brain radiation. So NRG launched the study based on a very successful phase 2 study by RTOG. So this is a phase 3 trial comparing whole brain radiation with momentum versus hippocampal avoidance whole brain radiation with momentum. The key eligibility criteria is that patients could not have metastasis within 5 millimeters of hippocampi. So this trial was published earlier this year in JCO. It is a positive trial. So hippocampal avoidance whole brain radiation is associated with prolonged time to cognitive failure and a better patient-reported outcome. Symptoms such as fatigue, difficulty with speaking, and there's no difference in overall survival or treatment-related toxicity. So this is exactly why we terminated our trial in September last year. MD Anderson was one of the sites for NRG-CC001, so we were aware of the trial results, and we knew that it was going to be practice changing, which was why we terminated our internal trial. Fortunately, we were able to pick up a signal between the two arms, even with incomplete accrual. So now we have two treatment options. So with hippocampal sparing with memantine, we have level 1 evidence to support its use in patients who need whole brain radiation. On the other hand, we have a phase 3 trial supporting the use of stereotactic radiosurgery in patients with 4 to 15 brain metastases. Which one would you offer to the patient? Say, if you have a patient with 10 brain metastases, what would you do? So this is the question we face daily in our clinic, and it's also the question we discuss at our weekly Brain Mets tumor board. So fortunately, there is a phase 3 randomized trial ongoing right now, run by the Canadian Clinical Trial Group. So the Canadian Clinical Trial Group actually 2 years ago launched a trial comparing SRS and whole brain radiation for 5 to 15 brain mets. So it's basically very similar to the MD Anderson in-house trial. However, shortly after they activated the trial, the NRG-CC001 results became available. So they converted this trial to SRS versus hippocampal avoidance whole brain radiation. So that trial is currently open for accrual in the US. It's open through Alliance and NRG group. So within MD Anderson, we're also in the process of developing a trial that's similar but a little bit different from this Canadian group trial. So now moving on to the second area of interest, management of resection cavity. In 2017, 2 phase 3 randomized trials were published back-to-back in Lancet Oncology. The first trial was MD Anderson in-house trial in patients with 1 to 3 metastases. After gross total resection of at least 1 metastasis, the cavity was randomized to FIS versus observation. The second trial is an NCCTG trial in patients with 1 to 4 mets. After resection, the gross total resection was not required. The cavity was randomized to SIS versus whole brain radiation. So the MD Anderson trial, where the cavity was randomized to SIS versus observation, the primary endpoint was local control. So it is a positive trial. The addition of SIS to the surgical cavity does reduce local recurrence. 1 year freedom from local control, from local recurrence is 43% versus 72% in favor of SIS. There is really no difference in toxicity between the two arms.
$200.
So the NCCTG trial, where the cavity was randomized to SIS and whole brain radiation. The primary endpoint was cognitive function, as shown in the curve on the left side, which represents cognitive deterioration-free survival. You can clearly see the separation of the two curves. At 6 months, the patients with cognitive deterioration was 85% for the whole brain radiation arm versus 52% for the SRS arm. Even though, again, whole brain radiation was able to improve intracranial control, it does not translate into a survival benefit. So based on these 2 studies, the SRS became the standard of care for the surgical cavity due to improved local control as compared to observation and better cognitive preservation as compared to whole brain radiation. But that's not the end of the story. There's still unanswered questions related to the cavity treatment. And one of them is the risk of LMD, and the other is what is the best radiation regimen for the cavity. As we all know, during the surgical resection, there's a risk of tumor spillage into the CSF or the ventricle. At least 1 in 7 patients who underwent resection of metastasis followed by radiation develop LMD. Even with post-op SRS to the surgical cavity, the risk of LMD can be as high as 28%. So in our in-house trial, comparing SRS with observation, the risk of LMD was about 20% for the whole population, so which is pretty high. On the other hand, in retrospective series, the risk of LMD can be as low as 3 or 4% in patients who received pre-op SRS. So the idea is that if you radiate the tumor first, even if there's tumor spillage during the resection, those tumor cells are dying or they're impaired, so it's unlikely that they will survive in the CSF. So for that reason, we launched a phase 3 randomized trial within MD Anderson Cancer Center comparing post-op versus pre-op SRS. The trial was led by one of our star junior faculty, Dr. Yuboa. It has been accruing very well. So hopefully we will be able to provide answer to this in the near future. So the other question is, what is the best radiation regimen for the cavity? Why are we asking that question? So let's go back to the NCCTG trial where they compared the cavity. They compared the whole brain versus SRS for the cavity. So when they look at the surgical bed control, they did not see a difference up until 9 months. And as you can see, at 9 months, there is separation of the 2 curves representing the surgical bed control. What was surprising was that the local control was better with whole brain radiation, not SRS. So this is surprising because we think that with SRS, we drop more dose to the surgical cavity, we should have a better or more durable control. That apparently is not the case. So what could have caused this? So one possibility is SRS-associated radiation necrosis. So the radiation necrosis sometimes can be interpreted as tumor recurrence. So another possibility is that the delineation of the surgical cavity. So for those of us who treat cavity on a regular basis, we know that it is challenging sometimes to delineate the extent of the surgical cavity. It's not always to decide where the cavity ends, where the sulcus starts. And with SRS, you do have a sharp dose fall off outside your target. So if you do not contour the cavity, you basically are not treating it. So is this increase the risk of recurrence due to the target delineation? So another possibility is that whether the biology is different, between different regimen. So when you look at the surgical bed control in the literature, as you see, there seems to be a better surgical bed control when fractionated SRS was used, as shown on the right side of your screen. So I know you cannot really compare different studies. However, but you can at least appreciate a trend. On the left side is single fraction SRS, and on the right side is the fractionated treatment. It seems that the surgical bed control is better. So if you think about it, we oftentimes determine whether we want to do single fraction or fractionated based on the size of the cavity. So the cavity that was treated with fractionated tend to be larger. So technically they could have a higher chance of having recurrence, but that's not the case. There's actually better local control when you use fractionated SRS. So that led to a new phase 3 trial launched by Alliance, comparing single fraction SRS versus fractionated SRS to the surgical cavity in 3 to 5 fractions based on the volume. So hopefully we will, from this study, we will be able to figure out what is the best regimen for the cavity. So in parallel with those efforts, there are some preclinical studies also provide evidence to support the use of fractionated treatment. in terms of inducing immune response. So the studies in the next few slides were performed by Dr. Fomenti and Dr. DiMario at Columbia University. So in this particular study, the tumor cells are injected into both flanks of the mice, and only one tumor is radiated. It's termed as primary tumor. And they examined the different radiation regimen, 20 gray in 1 fraction, 8 gray times 3, and 6 gray times 5. And they observed what happens with the unradiated tumor, which they call the secondary tumor here. So this is a very busy slide, but I want you to focus your attention on the 3 red arrows, because those represent the change in the size of the unradiated tumor. So as you can see, with 20 gray times 1, you don't see any really change in the secondary tumor. However, when you use 8 gray times 3, you see a significant growth delay in the unradiated tumor. And when you use 6 gray times 5, you also see a drop of the size of the unradiated tumor. So this basically